All right, I think we're on. Sorry, we're running a couple minutes late if you've been here. Um, my name is Dr. Kristen Wright. I'm the medical director of the New Hampshire Center at Boston IVF, and we are doing a Facebook Live today to talk about embryo grading. So we're going to go through some um, things that we think about when we're selecting which embryo to transfer for you at the time of an IVF cycle. And so I'll give you kind of an overview of that, and then at the end can answer any questions that you may have. So first off, there's different ways that we look at embryos when we consider which embryo we're going to transfer. The best tool that we have to determine which embryo to transfer for you is if we do an extra step in the process called PGTA testing. That's an extra step where we biopsy the embryos to see which embryos have chromosome problems and which don't. Many embryos look fine and normal to us in the petri dish, but have underlying chromosome problems such that they're not going to make a successful pregnancy. We can't tell that just by looking at the embryos, but we can tell that if we perform a biopsy. So the advantage of that testing is that it screens out embryos with chromosome abnormalities. Most chromosomally abnormal embryos just don't make a pregnancy at all. Other times they might make a pregnancy that would then miscarry. That's the most common cause for miscarriage to happen. And then more rarely, those issues can go to term. Things like Down syndrome, for example, is an extra chromosome 21, and we do pick that up with the PGT testing. There are some downsides to PGTA testing. The extra step of biopsying the embryos does make the process take longer for some couples. So in order to test embryos, we need to biopsy and then freeze those embryos to wait for the genetic test results to come back. With some couples, or some patients, we can do a fresh embryo transfer where we transfer the embryo back in the same cycle where we've done the egg retrieval procedure. So that is a faster process than freezing the embryos to wait for testing. The other downside is cost. It's a labor-intensive process to biopsy an embryo, and the genetic testing that's performed is pretty sophisticated, so there's additional cost associated with doing that extra testing. And then the third downside is that the testing isn't perfect. We could call a normal embryo abnormal or vice versa. We do still strongly encourage people who become pregnant with PGTA tested embryos to have their pregnancy screened for chromosome abnormalities, which would be done as just part of routine prenatal care. So that extra testing is very helpful to us. Again, it's kind of the single best tool that we have to determine which embryos are viable and likely to result in pregnancies and which embryos are not viable. The second way that we can assess embryos is to look at embryo morphology, which is just the appearance of the embryo in the petri dish. There's different ways that we look at embryos, so I'll show you some pictures of embryos just so you can get a visual of kind of what we're talking about here. I'll try to share the screen. Hopefully you can see this. So the top picture that we're looking at here is a day 1 embryo. So this is a fertilized egg. So on the day of an egg retrieval procedure, we retrieve eggs. We place the eggs together with a sperm, and then the next day we look at the embryos to determine which of the eggs have fertilized. So this top picture is a fertilized egg. It is just one cell, and it has 2 pronuclei. So the 2 little circles in the middle of that embryo are the nuclei. One is from the egg and one is from the sperm. So that tells us that this egg is fertilized and incorporated the sperm DNA into the embryo. These are sometimes referred to as 2PN embryos, which stands for 2 pronuclei, also sometimes referred to as zygotes. We cannot tell a lot about the quality of a zygote because it's just one cell. So we can tell that it's fertilized, and we really can't tell much about what that embryo is going to do at this stage. From here, the embryo will undergo exponential cell division. And the next stage of embryos is what's called the cleavage stage. So the top picture is a 2-cell embryo, then it goes to 4 cells, then it goes to 8 cells, and so on. On day 3 of embryo culture, so day 1 is the day of the fertilization check. On day 3, An embryo should be between 6 and 10 cells. We will occasionally transfer day 3 embryos. We don't do that very much anymore as IVF technology has gotten better. More commonly, we will grow embryos out into the blastocyst stage, which is day 5 or 6 of embryo culture. Back at the start of my career, we would do day 3 transfers all the time, but that's not done nearly as commonly anymore. However, there are some situations where transferring a day 3 embryo may make sense for you. So if you don't have a lot of embryos, if you only make 1 embryo, for example, if you're a lower responder, we're not really accomplishing anything by keeping that embryo in a petri dish. So sometimes we'll transfer that embryo just to put it back to its best possible environment sooner rather than later. The other situation in which we might consider a day 3 transfer is if someone has done prior IVF cycles and the embryos just don't progress from day 3 to day 5 very well. So sometimes we'll have lots of embryos on day 3, but then sometimes no embryos or very few embryos on day 5. That's relatively rare. It's usually just due to underlying biology, so not necessarily something we can change by doing an earlier transfer, because if the embryo is not going to make it, then it's not going to make it. But in some situations, patients may benefit from that if they've had poor blastulation in the past. We had a recent case, one of my colleagues had a second opinion patient who'd done multiple IVF cycles at another center and had just poor blastulation, poor blast developing. So we performed a day 3 transfer and she got pregnant. And the embryologist commented, was it the day 3 transfer? Was it a different IVF lab? Did we just get lucky? We never know. But there are some situations where day 3 transfers are considered. When we grade a day 3 embryo, we're going to look at the number of cells in the embryo. The optimal number of cells to have on the morning of day 3 is going to be 8 cells. 6 to 10 cells is kind of where it should be. All embryos will grow and divide at a slightly different rate. And then the other thing that we're going to look at is fragmentation of those cells. That is graded A to D. An A quality embryo has no fragments, meaning when the cells divide, they haven't thrown off any little fragments as they're dividing. And a D is a highly fragmented, poor quality embryo. So this is like school. We like to see A's and B's in terms of quality. C's and D's would have lower implantation and pregnancy rates with those lower quality embryos. But most of the time these days, we are going to be talking about transferring blastocysts. So between day 3, when an embryo is approximately 8 cells, from there it will continue to undergo exponential cell growth. On day 4 of embryo culture, embryos are usually at what's called the morula stage. That's just a ball of cells. We can no longer see the individual cells of a morula, and it has not yet split into the 2 different cell lines that characterize a blastocyst. By day 5, embryos are starting to reach the blastocyst stage. There are 6 stages of blastocyst development. And at this stage, the embryo is splitting into 2 different cell lines. The first cell line is called the trophectoderm, and the second cell line is called the inner cell mass. You're looking at 2-dimensional pictures of embryos here. Embryos are 3-dimensional structures, so when you look at these under the microscope, they kind of look like little beach balls. And then the cells on the outside of the beach ball are the trophectoderm cells. Those cells are destined to become the placenta and the extraembryonic tissues in the embryo. The inner cell mass, which is inside the little beach ball filled with fluid, is going to turn into the embryo. So as I said, there's 6 stages of this. At the first stage, the first and the second stage, the embryo is just starting to split into these 2 different cell lines. So you can see that there's not a lot of fluid in the middle of the embryo yet. The blastocele, which is the fluid on the inside of that little beach ball analogy I'm using, hasn't quite started, is just starting to develop at this stage. We can't usually grade the cell lines for a grade 1 or 2 blastocyst because they haven't yet quite split into those 2 separate cell lines that we can see really well. Once an embryo reaches the stage 3 blastocyst stage, we can start to see the inner cell mass and as well as the appearance of the trophectoderm. So the picture that's on the upper right there is a stage 3 blastocyst, and that little ball of cells that's at about 9 o'clock is the inner cell mass. We grade these two different cell lines, A to D, and it's, again, like school, we want to see A's and B's in terms of quality. A C quality embryo has very few cells. We cannot biopsy C quality embryos because there aren't enough cells for us to be able to take off the 5 to 10 cells that would be necessary for a biopsy. So stage C embryos are not biopsyable, but we can biopsy A and B quality embryos starting at stage 3 of the blastocyst development. And then stage 4, the blastocele, the fluid inside the embryo, has continued to expand. The stage 5 blastocyst is when the embryo starts to hatch. So there's a shell around this embryo. You can see that as a very faint line around the embryo. By stage 5, the blastocyst is the embryo starting to hatch out of that shell. So it has that little figure of 8 appearance as it's coming out of its shell and looking for a home, looking for a uterus. And then the stage 6 blastocyst stage is a fully hatched blastocyst. So that is an embryo that is completely outside of its shell. And so we can biopsy embryos stage 3 through stage 6 at any point here. All embryos will grow at a slightly different rate. So on the morning of day 5, when we check the embryos, we could have a mix of stage 1 blastocyst, stage 5 blastocysts. Sometimes embryos are still at the morula stage on day 5. We will continue embryos in culture up to day 7 after the egg retrieval procedure. And any embryo that makes it to a stage 3 blastocyst or higher and is A or B quality would then be biopsied if you're doing the PGTA testing, or frozen if we're not performing the PGTA testing. We can freeze embryos without that testing. If you're doing a fresh embryo transfer, where we're transferring the embryo back in the same cycle where we've done the egg retrieval procedure, then we would pick the embryo that's getting the best score and transfer that embryo back on the morning of day 5. When we think about what embryos to transfer, day 7 embryos, so that's an embryo that has not made it to a blastocyst stage until day 7, those are slower growing embryos. One of the most important things that we look at with embryo development is the rate at which the embryo develops. So we will select the embryo that is most developed on day 5 or day 6. Embryos that are not well developed on day 5 or day 6, but are developed by day 7, do still make pregnancies. However, the pregnancy rate for a day 7 embryo is lower. It's about 15 to 20% lower than your pregnancy rate if we were to transfer a day 5 or a day 6 embryo. So we like to see day 5 and 6 embryos that are A or B quality. We will select the A's from there. If you have multiple day 5 or 6 embryos that are A or B quality, we will look at the rate at which they developed, and then also look at those letter scores. So A's do better than B's, but just slightly. You're not talking about a huge difference in pregnancy rate there. So sometimes if we've done PGTA testing and patients have a preference for what sex of embryo to transfer, for example, you might have embryos that are very close in terms of their implantation potential, but we do look at the morphology. If you just want us to select the embryo that looks the best, then we would do that. Let me stop sharing my screen. So that's my overview. Let me see what questions you have. So first question, how long after PGT can you expect to do a frozen embryo transfer? So the PGT results take about 2 weeks to come back. So you do your egg retrieval procedure. We will grow the embryos in culture for as long as 7 days. So 1 week after the egg retrieval procedure, you will know how many embryos have been biopsied and sent off for testing. Test results, turnaround time is about 2 weeks from there. So about 3 to 4 weeks after your egg retrieval procedure, we'll have your PGT results back. We'll meet back with you at that point to go over those results. So you'll meet with your physician, talk about the results. And then we would, assuming you want to move forward with a transfer and have an embryo to transfer, we would move forward with the frozen embryo transfer procedure. So usually the way I describe this to patients, there's 1 cycle, 1 month where we're doing the egg retrieval part and growing the embryos. The next cycle or month is really a rest cycle where we're getting your results back, meeting back with you, making a plan, and then setting up for the second part, which is going to be your frozen embryo transfer. And then in the third month, the third cycle is when we would perform a frozen embryo transfer, and it takes about a month to do that type of a cycle. So if you're doing PGT testing from when you start IVF medications to getting to hopefully a positive pregnancy test is going to be about a 3-month process. So I hope that answers that question. Next question. On average, what is the rate of abnormal versus normal embryos? And is it strongly recommended to do PGTA testing? The answer is that this varies a lot, mostly based on age. As women age, a higher proportion of our eggs have random chromosome errors and therefore result in abnormal embryos. So for women under the age of 35, we would expect about 70% of the eggs or the embryos tested to be normal, but about 30% have abnormalities. That percentage goes down pretty substantially as you get older. For women over the age of 40, a majority of the embryos will actually have chromosome abnormalities, and a much smaller proportion of the embryos would be expected to be normal. So between age 35 and 40 is when we start to see that significant drop in quality of eggs and a higher proportion of abnormal embryos. And for that reason, PGTA testing is especially helpful for women who are older. So PGTA testing is really helpful for women over the age of 38. It's really dramatically changed how well IVF performs because back in the day, before PGTA testing, we would transfer embryos untested, and most of them just weren't normal embryos. So we didn't get the results that we wanted. So I would say it is, for most patients, strongly recommended for women who are over the age of 38. For women who are under the age of 35, the main advantage of the PGTA testing is that it's going to reduce your risk of miscarriage. And miscarriages are obviously tough to go through, especially when you've gone through infertility to get pregnant in the first place. So that's the main advantage of PGT testing in younger women. However, if you look at long-term outcomes, so your overall odds of having a baby, with or without PGTA testing for women under the age of 35, it's not absolutely necessary to do that because nature will tell you whether the embryo is okay or not. So I would say strongly recommended for most women who are over the age of 35 to 38. It's helpful for women who are under the age of 35, but it's not always completely necessary either. Next question, do more eggs guarantee a greater chance of success? The short answer is yes. This used to be debated. People used to wonder if you get a whole bunch of eggs, so if you put someone on higher doses of medications and they have really high egg yield, is that good? Are you just getting some bad eggs? Are you getting good eggs, but then also just a whole bunch of bad eggs? Or is the high dose stimulation hurting egg quality? So these used to be questions that we had. We've pretty much answered that question with studies, and including a study that one of the fellows at Boston IVF performed, which looked at what is your chance for pregnancy based on how many eggs have been retrieved. And the results of that study show that the more eggs you get, the more pregnancies you get. So in general, these days, we can pretty safely do more aggressive stimulations and get a lot of eggs for women who have a high response. And in general, that's in your best interest to do, because then hopefully you only have to go through the egg retrieval part once, as opposed to having to do multiple procedures. Not everybody's going to be a high responder, so not everybody's going to have a super high egg yield, and that's okay. But in general, the more eggs that we get, the higher the chance for pregnancy. But it only takes one good one, as we often say. Next question, any recommendations to improve my egg quality? This is a great question. I get this question a lot, and I wish I had a better answer to this question, because a lot of it is just underlying biology related to age, related to genetics, related potentially to environmental exposures, but what those exposures are is a little bit hard to say. I think that having a healthy lifestyle does influence egg quality. So we know that things like cigarette smoking can impair egg quality, other toxic habits, exposures to pesticides, those types of things impair egg quality. So trying to have a healthy diet, get some daily activity, avoiding toxic habits like cigarette smoking and exposures to pesticides is certainly recommended for you. And those are probably the best and most important things that you can do. And it's a lifelong effort because your eggs are sitting in your ovaries from when you're born. Lots of people ask about supplements. If you ask Dr. Google, there's all kinds of suggestions out there for things that might improve egg quality. None of it's particularly well studied, unfortunately. One supplement that many people take that's thought to maybe help with egg quality is CoQ10, which is an antioxidant. It's okay for you to take CoQ10. The studies that showing that it might work aren't super compelling, but it doesn't hurt anything to take that particular supplement. So that's okay to take if you'd like to. Any supplements that you take, though, you should make sure that you share that information with your doctor, because there are some things that we really don't want you taking during the IVF process. But the short answer is a healthy lifestyle is really the best thing that you can do. Next question, what does it mean to have an embryo grading of 4AB? So if you have a 4AB embryo, this is a blastocyst stage embryo. Was at the stage 4 blastocyst stage when it was frozen. And then the two letters are those two different cell lines that I was talking about earlier. The first letter is the grade of the inner cell mass. So the inner cell mass looked perfect. When I looked at it under the microscope, they gave it an A score. The trophectoderm, which is the outer cells in that embryo, the part of the embryo that's going to make the placenta, was a B score, which is also a good score. B just means that there were some slight irregularities there. So as long as this 4AB embryo was frozen for you on day 5 or 6 of embryo culture, this would be a very good embryo. Even if it was frozen on day 7, the chance of pregnancy would be a little bit lower in that case, but it could still certainly make a baby. And if that's your embryo, I hope that it does. Next question, which embryos are best for transfer, day 5 or day 6? Statistically speaking, for FET, I'll start with that. Which embryos are best to transfer, day 5 or day 6? If we're doing a fresh embryo transfer, we would perform that on day 5. If we're freezing embryos and then looking back at whether the embryos were frozen on day 5 or day 6, we just look at the rate at which they develop and pick the embryo that got the best score. So we're looking at day 5 and day 6 embryos pretty equally. Day 7s are the ones that we would rank a little bit lower. And then in that same question, statistically speaking, for FET, how many embryos untested are needed for one live birth, assume grade AA? So that's a good question. In general, if you're doing embryo banking, so if you want more than one child, for example, we will sometimes do more than one IVF cycle to try to bank a certain number of embryos. That would gives you the best chance of having more than one baby. So say you're 35 and you want 2 children and you're doing IVF. If you make one embryo, we can transfer that embryo, but if it works and you get pregnant and have a baby, by the time you come back for your second baby, you're going to be older and your success rates with IVF are going to be lower at that point, because that's what happens with age. So sometimes for women in that type of situation, we'll do repeated IVF cycles to try to bank a certain number of embryos. It is ideal to bank about 3 embryos per baby that you want to have. That does not guarantee that you would be successful. So if you bank 3 embryos, you're not guaranteed to have a baby with that number. But it generally, for most patients, would put your odds at greater than 90%. So pretty good odds of having at least one baby if you've got 3 embryos frozen. It's not always realistic to do that. So some women, make lots of embryos with an IVF cycle. Other women don't, especially as women get older, we sometimes see fewer embryos. So generally we would take this cycle by cycle and see how many embryos we have to work with, what your goals are for your ultimate family size, and then make a decision from there about whether to transfer embryos that we have versus trying to get more embryos. And insurance sometimes won't let you do repeated cycles, so sometimes we run into insurance restrictions with that approach. And then the last question from this participant was, how closely does embryo quality relate to PGT testing? PGT testing tells us a lot more about an embryo than embryo quality or morphology scores. So the PGT testing is much more informative than a morphology score. We would really look at the PGT results first. And then the second thing that we would look at would be the morphology score of the embryo. We see all the time that embryos that look perfect and beautiful and get a AA score, and then we test them and they're not chromosomally normal. Other times you might see a slower growing embryo, like a day 7 embryo, that doesn't look as good from a morphology perspective, but if it's normal, it's still got a decent chance of making a baby. So the PGT is more important than the embryo quality or morphology score that we would assign. Next question, is there any studies that statistically have the number of successful transfers with testing versus successful transfer without testing? What is the percentage of increase for a successful transfer? Yes. So PGT generally will improve the odds of an embryo taking by about 15%. So it's a higher chance that if we've tested the embryo that it takes, since if we don't test the embryo, sometimes we're transferring an abnormal embryo. And that number goes up as women get older. So for women over the age of 40, it is much more successful to transfer a tested embryo versus transferring an untested embryo. So that 15% difference is for our younger patients that have a better prognosis and have more normal embryos. If you do the testing, it improves your odds by about 15% with the first embryo that we transfer takes. And then the percentages go up from there if you do the testing over the age of 40. It is very helpful and significantly improves the odds that the embryo that we transfer is going to take. Next question, I have a high prolactin. Is that a bad thing for my transfer? You should have that corrected prior to transfer. Prolactin is a hormone that's normally just produced when a woman is breastfeeding or lactating. And that particular hormone kind of acts as nature's birth control and suppresses the reproductive hormones and can affect the implantation of an embryo. If you're not lactating, prolactin is sometimes abnormally produced by the pituitary gland in the brain. That doesn't usually cause significant health problems, but can cause issues with fertility. So we would usually treat that if you had a condition like that with either cabergoline or bromocriptine during your fertility treatment. That medication can be stopped once you're pregnant, but in the preconception phase, that should be treated if the prolactin is being produced abnormally. Next question says, my embryo stops growing on day 3. What could be the reasons for this? This is unfortunately very common and very normal. Many human embryos don't progress from day 1 to day 5. And we do see embryos that stop growing at that cleavage stage or day 3 stage, not uncommonly. Most likely this just wasn't a normal embryo. So humans aren't as fertile as some other animals are. Many human embryos just don't make babies. So if this had been an embryo that had been produced in your natural cycle, you probably just wouldn't have gotten pregnant that month. Hopefully you can try again. And we can sometimes we'll make suggestions to change protocols, for example, to try to get some more embryos to work with. The biggest thing that would be different if you try again is that it would be a different set of eggs, a different set of sperm, and hopefully you'd have a normal embryo that would progress if you did another cycle. Next question, for a 3-day transfer and the embryo is at 5 cells, is it wise to use that embryo? You can use that embryo. The 5-cell embryo on day 5 is a little bit underdeveloped. We would ideally like that embryo to be closer to 8 cells for it to have the best chance, the highest chance for a successful pregnancy. But embryo morphology is really not an all or none thing. I have absolutely seen successful pregnancies, even from 4-cell embryos that were transferred on day 3. Back when we did a lot of day 3 transfers, we would sometimes transfer 4-cell embryos, and they would result in babies. So the chance of this embryo making a baby is a little bit lower than if it was an 8-cell embryo, but all embryos develop at their own rate, and it might just be a slower developing, a late blooming embryo. So it is okay to use it if you would like, and hopefully it would work. What are disadvantages and advantages of implanting multiple embryos versus one at a time? So this has been a really significant change in IVF over the course of the last 10 to 15 years. At the start of my career, we pretty routinely transferred multiple embryos back to the uterus. And just because IVF technology wasn't as good, our ability to culture embryos wasn't as good, our ability to test embryos and tell which ones were going to work wasn't as good. But when we did that, we saw pretty high rates of multiple birth pregnancy sometimes. So twin rates and even triplet or more rates were high back in those days. These days, because we have a lot more tools, specifically the PGTA testing, that can help us hone in on which embryo is most likely to make a baby, we're pretty routinely transferring one embryo at a time these days. And in the long run, that's better for you. Twin and multiple birth pregnancies, twins are cute, but it's a higher risk pregnancy, and that includes a higher risk of losing the pregnancy or preterm birth, and that can sometimes lead to lifelong problems, handicaps, or even death of the baby. So our goal at the end of this is for you to have a healthy baby, and the safest way to have healthy babies is to have them one at a time. And in the long run, you're actually better off transferring one embryo at a time in terms of your overall success rate. So say we have 2 good embryos. If we look at your chances of becoming pregnant, if we transfer both of those embryos in one cycle, versus if we transfer one embryo at a time over 2 cycles, you're more likely to become pregnant if we transfer one embryo at a time over 2 cycles. So that's usually in your best interest to do in the long run. So there are some situations where we would transfer multiple embryos, but it's quite rare these days. A vast majority of transfers these days are single embryo transfers. And again, that's usually the safest and the most effective way to approach this. The next question, what is the success rate for a first-time IVF transfer? The answer to that is it depends on a lot of factors. So what's going to influence your success rate with IVF? There's a number of things that are going to influence that. Age plays a strong role in terms of your success rate. So younger women have higher success rates than women do as they get older. Your BMI influences your success rate. So obesity can have a negative impact on success rates with IVF. And then the diagnosis, so the underlying reason for your infertility, be that male factor, tubal factor, unexplained infertility, some of those diagnoses have a better success rate than others. And then the last thing that's going to affect it is your overall, your ovarian reserve. We will test your ovarian reserve when you come in to see how many eggs are in the ovaries, and that helps us know what type of response we'd expect to IVF medications. If there's lots of eggs to work with, you'd have a higher success rate than if there's fewer eggs to work with. There's personalized calculators that we can use. So when you have an appointment with your doctor, they will do some testing as an initial step for you, and then based on the results of that testing, they can put all of this information into a personalized calculator, and that will give you a pretty accurate assessment of what your success rate would be with an IVF cycle. Thank you so much for doing this. You're welcome. From anonymous attendee. The next question says, what is the danger of genetically testing the embryo after it has been frozen? Does this increase success rates? Let's say I have lots of good quality embryos. Which ones would I want to transfer first? So we can go back and test embryos that have already been frozen. In order to do that, we need to thaw the embryos, biopsy them, and then refreeze them. The biggest risk to going back and testing embryos that we've already frozen is that you may lose some embryos in that process. When we thaw the embryo, most embryos will survive a freeze thaw, but the embryo would then have to progress and continue to divide and culture so that we can perform a biopsy on the embryo. When we do PGT, we will usually perform what's called zonal lasering on day 3, which means that we would make a little hole in the shell around the embryo. And what that does is allow us to perform a biopsy because some of the cells will come out of that little hole that we've made. When we haven't done zonal lasering, then we have to rely on the embryo to hatch on its own in order for us to perform the biopsy. So you have a number of good quality embryos there. So you certainly could go back and test them. Just keep in mind that you may lose a couple of embryos in that process. If you do that, you may not. It just depends on how the embryos do. Going back and testing them, it doesn't help you get pregnant with that embryo to biopsy it, but it does tell you which embryos are likely to be normal and which ones aren't. So if we test the embryo and we know that it's normal, that's going to have that embryo would have a higher chance of making a baby as opposed to an untested embryo, because sometimes the untested embryos just aren't normal. But it looks like you have a lot of embryos to work with there, so that's certainly encouraging for you. Next question, is it possible for A quality eggs to not implant? What are the possible reasons? What changes a person can do for future embryos for a successful implantation? So unfortunately, it is very common for A quality embryos to not implant. As we've talked about, the score that we give the embryo is not 100%. It's somewhat predictive of whether the embryo will make a baby, but not 100% predictive. And we know that many A quality embryos don't make babies. What are the possible reasons? Most of the time it's an embryo factor, not a uterus factor. So if we've tested the embryo, we've screened out embryos that have obvious chromosome errors. But that doesn't tell us everything about the embryo. There's still a lot that an embryo has to do in order to make a successful pregnancy. So going from a sperm and an egg to a human, it's a complicated process, and there's a lot of steps that have to happen. We don't even know what all of those steps are, and there's just a lot that can go wrong in that process. So most of the time when an embryo doesn't take, even though it got a good score, it is likely still just an embryo issue. The biggest thing that would be different for you in a future embryo transfer is that it would be a different embryo. There are other things that influence success rates and are necessary for implantation. So there's uterine factors too. If you've had 2 to 3 unsuccessful embryo transfers of tested embryos and you're not getting pregnant, that's the point at which we might start to do a deeper dive and recommend additional testing to look at the uterus to see if we're missing anything that could be impacting implantation. Before any IVF cycle, your doctor will look at your uterus, look inside the uterus, make sure that there's nothing structural on the inside of the uterus that could be impacting implantation. So those things are all identified before we'd even start an IVF cycle. But again, most of the time it's an embryo issue. And the biggest thing, if we try again, that would be different, is that it would be a different embryo. What is your experience with Zymot for getting better embryos? Yeah, so we don't have a ton of experience with the Zymot. Zymot is a new technique that's used for sperm sorting. So for selecting the best quality sperm to put together with the eggs. And the thought is that might improve embryo development. Results have been a little bit mixed with that. So there's some studies showing that it probably doesn't seem to make too much of a difference. It is something that we think about if we think that the sperm is contributing to the reason why an embryo isn't developing the way that we would like. So Zymot is one of the tools that we can use to try to select the better sperm. Most people don't benefit from that, but some people might. The other technique we can use to try to pick a good sperm is something called PICSI, which is physiologic ICSI. That's also an additional the sperm selection tool that we use to select the best embryo, or sorry, to select the best sperm to put together with the egg. So those are some things that we think about if we're concerned about the sperm contributing to the overall embryo development. Next question, if the embryo is abnormal, can it correct itself? That's a good question. And it kind of leads into the next question that I see there, which is what are mosaic embryos? So when we test an embryo for PGTA testing, we are hoping to see that the embryo has 2 of every single chromosome. If the embryo has 3 of a particular chromosome, or if it has only 1 of a particular chromosome, then that embryo is chromosomally abnormal and not likely to make a baby. What we sometimes see is what's called a mosaic embryo, where it looks like some of the cells might have the 2 chromosomes that we're looking for, but some of the cells are either missing a chromosome or have an extra chromosome. Some of those embryos are truly mosaic, meaning that once the embryo started, the cells in the embryo started to divide, that there was an error with one of those divisions, such that the chromosomes became unbalanced in one of the cell lines. And those embryos can sometimes correct themselves because sometimes those abnormal cells will just be confined to the placenta. And the baby itself, the inner cell mass, may not be impacted by that, because when we biopsy embryos, we're biopsying the trophectoderm part of the embryo. That's the part that becomes the placenta. We're not biopsying the inner cell mass, and that's the part of the embryo that becomes the baby. So that if we biopsy the trophectoderm and we see a mosaic finding, we don't know if the inner cell mass is okay or not. In many cases, it actually is okay. And so mosaic embryos can certainly result in successful pregnancies. The other thing is when you look at the data, the raw data from this, it's not perfect. There's always some scatter in the data. So where we set our thresholds for PGTA testing for calling an embryo abnormal versus normal has changed as we've learned more about what those set points should be and what the implications of these types of findings are. So we will screen out embryos that are truly abnormal, that all of the cells were missing a chromosome, or all of the cells had an extra chromosome. Mosaic embryos we will consider for transfer because we know that many of those embryos actually do just fine, and the babies do well. So it's a complicated topic, mosaicism, but I hope that helps to answer that question. And then next question, is it true that more times frozen, thawed, or biopsied, the higher the miscarriage rate? So yes, if we will sometimes have situations where we've performed PGTA testing and the results came back as inconclusive. So when we biopsy the embryo, we're taking off 5 to 10 cells. Sometimes when we perform that biopsy, there's not enough DNA in the biopsy for the test to be able to be performed. So sometimes we get a non-diagnostic biopsy. That doesn't happen a lot, but it can happen. In that case, we don't know whether we don't get any results, so we don't know what the status is on that embryo. We can then rebiopsy that embryo, which is what we would usually do. So we'd usually rebiopsy it to try to figure out whether it's normal or not. And usually those rebiopsies are successful in giving us an answer. However, the embryos that have been rebiopsied do not make pregnant. It affects the viability of the embryo. So it means that if we've taken off even more cells of the trophectoderm, that embryo does have a lower chance of making a baby when you perform a second biopsy. And the miscarriage risk in some studies has also been shown to be higher. So it's not ideal to rebiopsy an embryo. Something we do have to do it sometimes. But if you have an embryo that's been rebiopsied, we would generally rank that one last for transfer. So we would prefer to transfer an embryo that's only been biopsied one time as opposed to an embryo that's had to undergo multiple biopsies, just because we know that it can affect the viability of that embryo. Next question, is there any harm or benefits of transferring frozen versus fresh embryos? There's pros and cons to transferring frozen versus fresh embryos. These days, most of the time we're transferring frozen embryos as opposed to fresh embryos. That's really been a change in IVF, again, as technology has gotten better. The main advantage of transferring fresh embryos is that it happens faster. So you potentially get pregnant faster if we transfer the embryo in the same cycle where we've done the egg retrieval procedure. But there is some data that fresh embryo transfers may have some slightly increased obstetric risks, so increased risks of having placental problems in the pregnancy. And frozen embryo transfers have a lower chance of that happening. The other advantage of frozen embryos versus fresh embryos is that if we freeze the embryos, you are not at risk for something called ovarian hyperstimulation syndrome, which is a complication that we sometimes see if we perform a fresh embryo transfer. So it depends a little bit on your age and your hormonal parameters during IVF. If any of your hormone levels get to be too high, so we will watch two hormones during the IVF cycle. One is going to be your estrogen and the other one is your progesterone. If either of those hormone levels get to be too high during an IVF cycle, you shouldn't have a fresh embryo transfer because first of all, you're a little bit less likely to get pregnant when you have higher hormone levels like that. And secondly, you would be at risk potentially for ovarian hyperstimulation syndrome. So if you're trying for a fresh embryo transfer and you have a high response or either of those hormones bump to be too high, then usually we would convert those cycles to freezing the embryos. And then the other advantage of freezing embryos is just that we have the option to perform that extra PGTA testing. One other advantage of fresh embryos, though, in order to do PGTA testing and to freeze embryos, we usually need good quality blastocysts. If you're not someone who makes good quality blastocysts and you have poorer quality embryos, those embryos probably aren't going to do well with a freeze thaw or a biopsy, but they can sometimes result in pregnancy. So sometimes a fresh embryo transfer is a benefit in that particular situation. So those are kind of the things that we think about when deciding on a frozen versus a fresh embryo transfer. Let me see how we're doing on time. A few more minutes. So next question, is a grade 6 better than a grade 5, even though it already completely hatched? So a grade 6 blastocyst is fully hatched outside of its shell. It has advanced further than a grade 5 embryo. So in general, we would transfer, all things being equal, a grade 6 over a grade 5, although grade 5 blastocysts are a little bit more fragile because they're outside of their shell. So embryologists will say that they're sometimes a little bit harder to work with, a little bit harder to biopsy. They're a little kind of stickier. They're not protected by that nice shell. So, I mean, we handle them all the time and they do just fine, but it's not a bad thing to have an embryo that's still in the shell a little bit, just because that actually protects the embryo a little bit. But all things being equal, grade 6 versus day 5 or grade 5, we would select the grade 6 since it has progressed a little bit further. Do they need for patients to undergo any more preparation before transferring an embryo after PGTA testing? So I don't know if you're referring to the uterine preparation there. In order to transfer an embryo, it doesn't matter whether it's undergone PGTA testing or if it's just an untested frozen embryo. The frozen embryo transfer procedure would be the same. It doesn't differ based on whether or not we've tested the embryo. And then next question, can PGT be done at frozen embryos prior to a transfer? So again, you can go back and test embryos that we've already frozen. It's ideal to do the testing up front. So it's ideal to biopsy the embryos once they're made and then freeze them, as opposed to going back and thawing them, just because there's a small risk you're going to lose the embryo in the freeze thaw, or that the embryo is not going to progress to a stage where we can biopsy it. So ideally, we would do the PGT testing at the time of the initial embryo culture, but you can go back and freeze the embryos and test them if you'd like to do that. Next question, we did our first embryo transfer 2 weeks ago. The grade was 4BA, so good score. Unfortunately, the transfer failed. What are the most common reasons for an embryo transfer failure? Yeah, so I addressed this a little bit earlier. Even though that embryo got a good score, it doesn't tell us everything about the embryo. There's still a lot that an embryo has to do after we put it back to the uterus to make a successful pregnancy. And many embryos just unfortunately don't continue to grow and divide. So the most common reason for an embryo not to take is an embryo factor, and trying again with a different embryo, you will hopefully have a better result. There can be uterine factors as well. So your doctor will usually check to make sure that the uterus looks okay, to make sure the lining of the uterus is developed okay during the embryo transfer cycle. And then we'll want to make sure there aren't any structural problems in the uterus like polyps or fibroids. Sometimes we'll look for infectious cells or inflammatory cells that are in the lining of the uterus. That's something else that can be checked. But if this was your first transfer and it didn't take, I know it's of course hard to do all of this and really hard to have a negative result. But if you made a nice embryo with your first cycle, hopefully you'll make some more nice embryos if you cycle again, and hopefully you'll be able to achieve a pregnancy. So best of luck to you. Next question, is there a typical or average attrition rate at the grading stage? How many might be A or B quality? This varies so much from person to person. So it really is highly variable. And we really don't know until we do it. There aren't a lot of good tests that predict egg quality or that predict embryo quality. So we really don't know how many good quality embryos we're going to have until we get to that stage. For women under the age of 35, usually on average, over half of embryos will arrest and stop growing in culture. So the number of embryos that you have on day one is going to drop usually by about half when you get to day 5 or 6. But again, that varies so much. So sometimes we get 20 eggs and we get only one a good quality embryo. Other times we might only get 2 eggs and we get 2 embryos. So it's really highly variable, unfortunately. And I wish we had better predictive tools to look at that, but it varies a lot from patient to patient. Next question, I have Hashimoto's, and we have a 3BB, 4BB frozen. Didn't elect PGT testing, but would that be determined if autoimmune disorder gets passed on? So no, PGTA, there's different types of PGT. The PGT I've been referring to in this talk is PGTA testing, and that stands for pre-implantation genetic testing for aneuploidy. So aneuploidy is an embryo with an abnormal number of chromosomes. So it's chromosome screening is what we're doing when we perform PGTA testing. There is PGTM testing that you can do if you know that you are a carrier for a genetic condition that is likely to be passed on to your child. Then we can test your embryos for that particular condition, but that is a very specific test. We have to know exactly what we're looking for, so you would need to be tested first. So all patients who come to us are offered genetic testing for a bunch of genetic diseases, so we can determine whether that is something that could affect you or not. But Hashimoto's is a really common disorder. It's not caused by any single one gene, at least as far as we know. So it's not something that we could test an embryo for. So it would not be possible for you to test your embryos for that particular condition. Hashimoto's is pretty common. It's usually successfully treated with thyroid replacement. So hopefully, obviously, I assume that you're undergoing that type of treatment. But that's not something we would have identified if we had tested your embryos for PGT. Next question, if you aren't doing PGTA testing, is it the same timeline? The answer is it depends. If we are going to freeze your embryos anyway, then the timeline is the same whether you're doing PGTA testing or you're not doing PGTA testing. So for freezing embryos, it is usually still a 3-month process from starting medications to getting to hopefully a positive pregnancy test. The reason for that is mostly logistics. So when we do the egg collection cycle, we need to know the results of that cycle before we set up for the next cycle of doing a frozen embryo transfer. So there is usually a rest cycle between an egg retrieval cycle and a frozen embryo transfer cycle. So if we're freezing embryos, the timeline is not really different. If you are a candidate for a fresh embryo transfer, which you may or may not be, there's pros and cons to doing a fresh embryo transfer, then that can happen faster. And we can't perform PGTA testing on fresh embryos. So if it's possible to do a fresh embryo transfer for you, then that would be a shorter time frame than doing PGTA. Next question, if getting pregnant is a numbers game, yes it is, what is the number of embryos that are needed for a live birth, assuming over age 38? Yeah, so we talked about that as well a little bit earlier. In an ideal world, we would bank about 3 embryos per baby that you want to have. That does not guarantee that you would be successful, but puts the odds in your favor. If you're over the age of 38 and you're looking at embryo banking, I would recommend that you do the PGTA testing, just because a lot of the embryos at that age are going to be abnormal. And so that testing is really going to help us narrow in on the embryos that are likely to work for you, so we don't spend a bunch of time transferring embryos that aren't going to make it. All right, let me see how we're doing on time. All right, I'll take about 2 more questions and then we can wrap it up here. Would you expect PGTA embryos? Not sure I understand that question. I'm gonna just move on to the next question. Can you do PGTA and PGTM testing? I need to do PGTM due to a genetic condition. Yes, you can do those concurrently. So if you're doing PGTM, which is a specific test for a genetic condition that you're known to carry, we will pretty routinely also do the PGTA, where we look at the number of chromosomes in the embryo. So yes, those 2 tests would generally be done together. It would be pretty unusual to do the PGTM without the PGTA, just because if we're already biopsying your embryo, we might as well test as many things as we can test and not transfer an embryo that's abnormal. So usually both of those things would be tested. All right. Let me do, what are some of the factors that make someone have a more robust response to the egg retrieval process? This is mostly underlying ovarian reserve, so the number of eggs that are in the ovaries. And that's something that is tested usually before you start the IVF process, so we know what dosing of medications to use for you and what protocol. A lot of that is age and is just underlying genetics. So that's not something you can necessarily influence. It's just kind of the underlying biology that we have to work with. And how does sperm health affect embryo grading? It affects embryo grading. So the same lifestyle factors that I recommended for women, I also recommend for men. So having a healthy diet, getting some exercise, avoiding reproductive toxins, that's really important for everybody, and it's important for you throughout your life, so that you have good health of your eggs and your sperm. I have a nice thank you note from a patient here. So thank you for that, those kind words. I really appreciate that. Helping you guys make your families is why we do what we do. It really makes us happy to see people who've been successful. And if you're obviously on this journey, I hope that you will find success. So I think we'll probably wrap it up here, if that's okay. And I thank you for joining us tonight. And if you need to schedule an appointment, you can call our main office line to schedule a new patient visit. If you're already seeing someone, I wish you all the best.